Good day, everyone. For today's educational session, brought to you by your Education and Training Department, we shall discuss the basics of mechanical ventilation. At the end of 30 minutes discussion, you shall be able to define what mechanical ventilation is, discuss the different indications of mechanical ventilation, identify different mechanical ventilation basic setups, integrate key learning points on current home care setup or home care practice, and present various emergency scenarios and their respective care plans to implement. So, what is mechanical ventilation all about? You can see in the picture being presented in your screen is a sample patient with endotracheal tube hooked to a mechanical ventilator. We all know that your mechanical ventilator is an advanced airway equipment or airway system that supports the patient's respiration. But let us try now to define what mechanical ventilation is really all about. Mechanical ventilation is a form of life support. A mechanical ventilator is a machine that takes over the work of breathing when a person is not able to breathe enough on their own. The mechanical ventilator is also called a ventilator, respirator, or some others would call it as a breathing machine in general. There are many reasons why a patient may need a ventilator, but low oxygen level or severe shortness of breath from an infection, such as your pneumonia, respiratory failure, COVID-19, pneumothorax, and other respiratory medical conditions are the most common reasons. So there are types of mechanical ventilation if we're going to look in various textbooks. Modern mechanical ventilators use positive pressure to push air into your lungs. Take note, modern mechanical ventilators use positive pressure to push air into your lungs. Positive pressure ventilation can be invasive or non-invasive by nature. Again, you need to remember this one. When BNS or when HMC would ask you during visits, positive pressure ventilation can be invasive or non-invasive. So what is invasive and non-invasive ventilation? Invasive mechanical ventilation, this means that you have a tube in your airway connected to a ventilator. This tube can go through your mouth, through intubation, or through your neck, which is common in our area, through your tracheostomy. On the other hand, when we talk about your non-invasive ventilation, this is a use of a face mask connected to a ventilator. Straps hold the mask to your head to hold it tight. The ventilator pushes air into your lungs. Forms of non-invasive ventilation include devices you might use at home, like your CPAP or BiPAP level positive airway pressure, often known as a trade name BiPAP. So I think most of you have already encountered CPAPs and BiPAP hooked to a BiPAP machine or CPAP machine as well. But in general, your mechanical ventilator also can be hooked into a CPAP or BiPAP mask, not only with your endotracheal tube nor your tracheostomy. Okay, so why are ventilators used? Again, as we have described or as we have discussed in our discussion a while ago, your ventilators are used to deliver high concentrations of oxygen into the lungs, especially for patients who are experiencing increased level of CO2 due to medical conditions in their body. No, this is also to help get rid of carbon dioxide, such as patients who are suffering from respiratory alkalosis or respiratory acidosis. Also, this is to decrease the amount of energy a patient uses on breathing, so their body can concentrate on fighting infections or recovering. To breathe for a person who is not breathing because of injury to the nervous system, such as your stroke or such as those with trauma in their head, like the brain or spinal cord, and who has very weak muscles, such as patients who have neurogenic disorders, such as multiple sclerosis, ALS, all right, and Guillain-Barré syndrome. To breathe for a patient who is unconscious because of a severe infection, buildup of toxins, or drug overdose rather, you can use your mechanical ventilators. Okay, so specific conditions. So when being asked during your competency fair or during your assessment, right? You use your ventilators for cardiac or respiratory arrest. You use your ventilators for tachypnea or bradycardic patients with respiratory fatigue or impending arrest. You use also your ventilators for acute respiratory acidosis, just what like I said a while ago, refractory hypoxemia, inability to protect the airway associated with depressed level of consciousness for patients with cerebrovascular accidents, shock associated with excessive respiratory work, and inability to clear secretion with impaired gas exchange or excessive respiratory work, and lastly for elective surgery with the use of anesthesia. So all of these medical conditions or all of these situations, you need to use your mechanical ventilator. Now, basic setups, no? I always discuss this to our new nurses, no, because this is very important as patients no, can have ventilators at home as well. So there are really a lot of ventilator modes that you can see, but we will only discuss three of them now because these are the three very most important ventilator modes that you need to remember or understand. You have your AC mode or your assist control mode. You have your SIMV mode, which is your synchronized intermittent mandatory ventilation, and you have your spontaneous mode. Okay, so when we talk about your assistive control mode or your AC mode, breaths are delivered by the ventilator control either volume or pressure. So the one being in charge here is the ventilator. The ventilator delivers the same measured breath every time, and breaths can be initiated by the patient or by the ventilator. It only means that with the triggering factor coming from the patient, or whether the patient does not breathe on his own, ventilators on AC mode will deliver the pressure needed or the volume needed for the patient to breathe. Again, just to make it simple, the one in charge here is the ventilator. The one in charge for breathing is your ventilator. On the other hand, when we talk about your synchronized intermittent mandatory ventilation, or most commonly heard your SIMV mode, combination of a set of patient or ventilator-initiated breaths delivered by the ventilator that control volume or pressure and the patient's own spontaneous breath. So, okay, so for your SIMV mode, the ventilator now will synchronize the air being delivered or the oxygen being delivered by the spontaneous breaths of your patient. More of like a 50-50 scenario. Each of which the patient and the ventilator will meet halfway, 50-50% of the effort so that the patient can breathe easily. On the other hand, comparing to your AC mode, when you say it's AC mode, the work or the one in charge would be the ventilator in initiating the ventilation or initiating the breathing of the patient with or with a trigger coming from the patient. But when we talk about your SIMV mode, the ventilator goes together, is synchronized with the spontaneous breath of your patient. Again, AC mode, the breathing or the breathing would the main in charge for the breathing would be the ventilator. On the other hand, for SIMV, it should be on the 50-50 scheme, wherein the ventilator would go together, would be synchronized with the spontaneous breaths of your patient. Lastly, you also have your spontaneous mode. Now, this is patient initiated and sustained breathing. Ventilator controls oxygen amount only and the pressure being delivered, and delivers flow and volume as needed. Again, keyword there, spontaneous as needed to help the patient breathe. Also, patient can breathe at continuous positive airway pressure. Now, from the word spontaneous, meaning as the patient needs to be supported, then the ventilator comes in to support the patient's breathing. All right, so again, in summary, to make it more easy and not complex on your part, AC mode, the ventilator is the one in charge, no, in delivering the oxygen and delivering the volume and pressure needed for the patient to breathe with or without initiation from the spontaneous breathing of your patient. On the other hand, SIMV mode, no, it's a 50-50 scheme wherein the patient and the ventilator shall meet halfway. The ventilator needs to go synchronize with the spontaneous breaths of your patient. On the other hand, when you talk about spontaneous mode, keyword only as needed to help the patient breathe. All right. So take note that this different settings, no, are changed by the physician and the respiratory therapist depending on the patient's assessment or respiratory status. Okay, so the process of decreasing the ventilator mode or changing the ventilator mode and decreasing the required setup is called the weaning process. So you need to remember this. Okay, next you also have the different ventilator breath types, which is your volume control ventilation, the pressure control ventilation, and the pressure support ventilation. Alright, this is the breath. This is the type of breathing delivered by the ventilator specifically. So we will not dwell much on this one. You just need to master the three ventilator modes which I have discussed a while ago. Next, how does a ventilator work? So basically, when a person needs to be on ventilator, a healthcare provider will insert an endotracheal tube through the patient's nose or mouth, but most of the time mouth, and into their windpipe or trachea. Okay, so the ventilator pushes a mixture of air and oxygen into the patient's lungs to get oxygen into the body. The ventilator also can hold a constant amount of low pressure called your positive end expiratory pressure, or your PEEP or your PEEP, in order to keep the air sacs in the lung from collapsing, which is very important. If you are familiar with the different ventilator, your PEEP affects the blood pressure of your patient. Okay, so this is an example of how a ventilator screen looks like. If you're going to look at the oxygen there with the 21%, so basically this is the lowest mode that the patient can have, the lowest oxygen that the ventilator can deliver. You have your PEEP there by cm per water, and you have your percent minute volume. If you would see the screen, the patient is on ASV mode. Okay, is on ASV mode. So this is how your Hamilton C1 screen look like, and this is a touch screen. So I don't know if you have already seen one, but I think the most common type of ventilator in the area is their Newport ventilator, which I will show you a picture of it later on. Okay, so this is how your ventilator, basically how a ventilator looks like, whether the patient is on endotracheal tube or whether the patient is in tracheostomy. This is hooked to a mechanical ventilator, and usually there is two separate tubes wherein the air flowing to the patient and the air being exhaled is being connected to each other. Okay, so how does the ventilator work also? The other part, if the endotracheal tube does not work already, and if the patient is for long-term ventilation, then the patient shall have what we call your tracheostomy, which I believe the Miss Bonnie on the next video, she will discuss to you the parts, the indications, and the things to remember about your tracheostomy. So if a person has a blockage in the trachea, such as tumor, or need a ventilator for a long period of time, then the patient needs your tracheostomy. So the tracheostomy tube is then connected to the ventilator. So a tracheostomy tube can stay in as long as needed, but does not have to be permanent and can be removed if a patient no longer needs it. Okay, again, you need to remember that your tracheostomy can be temporary or can be permanent in nature, depending on the need or indication for the patient's respiratory status. Also, based on our policy, your tracheostomy can be changed every after 3 months, or depending on the assessment of the physician with the tracheostomy of your patient. So you have your tracheostomy basics here. You have your pilot balloon, you have your cuff, your outer cannula, inner cannula, obturator, your flange, your faceplate. So I believe that this will be discussed by Miss Bonnie later on the next video. Okay. Next, how long is a ventilator used? So a ventilator can be life-saving, but it also has its risks, which I will discuss later on. Weaning refers to the process of getting the patient off the ventilator, and some patients may be on ventilator for only a few hours or days, while others may require the ventilator for a longer period of time. Again, just like what I've said a while ago, your ventilators can be temporary or permanent by nature. So how long a patient needs to be on ventilator depends on many factors. So this can include overall strength of the lungs, how well their lungs were before going on ventilator, and how many other organs are affected like the brain, heart, and kidneys. Another concept that you need to remember for your ventilator is how to address an alarm. Right? In your mechanical ventilator, now there are two types of alarm that you need to address or that you need to remember. You have your high pressure alarm and you have your low pressure alarm. For your high pressure alarm, usually this is caused by any resistance. Again, for your high pressure alarm, this is usually caused by any resistance. A good example of this one is when your patient coughs, there is partial or a complete tube block. It means that your tracheostomy is blocked by a bolus of secretion. Increase in production of the secretion as well. There is filter block. Your heat-moist exchange filter is blocked. Patient fighting with the ventilator. It means that the patient goes against with the settings being administered by the ventilation. There is presence of bronchospasm, pneumothorax, abdominal distension, ARDS, kink in the tube rather, endotracheal intubation, water in the circuit. Circuit is a part of the ventilator, and the alarm limit setting. Maybe the alarm limit setting of the ventilator is too low. On the other hand, when the patient has low pressure alarm or leak, you need to check the airway, the tracheostomy tube. Maybe it has been detached, any disconnection in the circuit. All right, the tracheostomy cuff pressure is too low. Check the closed suction adapter. Maybe it has been detached as well. The heat-moist exchange filter adapter have been detached as well. There is the leak in the nebulization connection, the circuit again of the ventilator, and the alarm limit setting is too low or too high. Okay, so you need to remember these things. Again, for high alert pressure, more on resistance coming from the patient's side, and low pressure alarm, there is leaking coming from the ventilator side. Okay, so what are the risks of your mechanical ventilation, or basically some of the complications that you need to remember? Number one, you have your bacterial infections, right? So the tube in your airways can bring bacteria into the lungs, causing infections like ventilator-associated pneumonia. Again, you need to remember your ventilator-associated pneumonia. Again, your ventilator-associated pneumonia. You also have your lung damage, pneumothorax or atelectasis, when there is excessive air being administered, or maybe the position of the endotracheal tube or the tracheostomy is not in place. Heart and blood flow changes if your heart doesn't work as well, or there is a decrease in your blood pressure or a raise in your heart rate. And of course, in some rare cases, subcutaneous emphysema, because of the tracheostomy, the newly inserted tracheostomy is not in place or not patent as well, wherein the air seeps into the subcutaneous tissues of your neck area. Okay, so this can cause complications in your mechanical ventilation. So these are some of the common equipments that we use in the area. You have your Hamilton C1, you have your Trilogy Respironics, and you have your Newport ventilator. And I believe that your Newport ventilator is the one of the most common here. Alright, some others also have the Hamilton C1. This is one of the newest and more high-tech than the three of them. So here you can see, so these are some of the example photos that we have obtained during our training. And the next topic would be something about your tracheostomy, which is also very important, which will be included in your competency fair as well. All right, so this discussion or this session only is just a part one, as you will have your part two or your skills or your macro demonstration soon when the schedules already being arranged. All right, that would be all. Thank you.